You had mentioned that for the moment it's injectables, but Pioneer 6, that was another interesting study that people were talking about, is an oral GLP-1. So one of the problems is that GLP-1 is a big protein. So how do you get that into your system without breaking down? Like I can't swallow insulin and get it into my body. I'm sure all our patients would love to do that. So David, you're the mechanistic guy. So how did they get, a GLP-1 to go in a pill form?
This is a hugely clever process that's taken place because, as you say, peptides, as soon as they hit the stomach, they just become metabolized. They become broken down, and it's been almost impossible to this moment to get any peptide orally. And what the very clever scientists have managed to do is put a protein, a snack protein, do not expect me to do the full name for it, but snack protein, sits nicely with the semaglutide, and it enables it to be absorbed. Now, we still need to have a very high dose of the semaglutide in order to do this. So to put it into context, when we're injecting 1 milligram a week. When we're taking it as a tablet, we're taking 14 milligrams a day. So we're having to give exponentially higher doses in order to achieve the same glycemic concentration. But what we do find is you get that glycemic concentration of the semaglutide, which is enabled to give you very, very similar results when it comes to HbA1c reduction and weight loss, with the added advantage that because it's being absorbed through the stomach, it's actually going to where it needs to go. It's ending up into the portal system, and so the first point of call for it is going to be the liver before it then gets distributed around the body, as opposed to a subcutaneous injection, which goes round the body in the first place.
So unfortunately, it's physiologically makes sense, but then it gets removed. So therefore, you need much more of it. Okay. All right. So now we have an oral version of it, and that's why Pioneer 6 was interesting, because this was a safety trial. So therefore, a safety trial, it's 3,183, so a little bit smaller, a little bit shorter in duration. 15.9 months is the median. They also had primary and secondary patients. So secondary would be people over 50 with heart disease, cardiovascular disease, or kidney disease, and then primary prevention would be people over 60 with risk factors. So they had a mixture of the two just to see are these agents safe. And so David, maybe I'll turn it to you in terms of the results of Pioneer 6, because it's a very tiny study. It shouldn't have received the attention that it did, but I think because it's an oral GLP-1, I think that's why people paid attention.
Well, as you mentioned, this is a CV safety trial to demonstrate that there's no 80% excess in CV mortality as mandated by the FDA. It's a smaller study with just over 1,600 people in each arm. Standard of care randomized to placebo or semaglutide, but orally 14 milligrams as opposed to the equivalent of 1 milligram subcutaneously. And after a very short median of 16 months, just under 16 months, there was observed a 21% relative risk reduction in the 3-point MACE. Again, non-fatal MI, non-fatal stroke, and cardiovascular mortality. Unfortunately, the statistical results did not show significance in the primary endpoint. However, in terms of the secondary pre-specified endpoint, in terms of components of the 3-point MACE, there was close to a 50% reduction in cardiovascular mortality as well as in all-cause mortality. And in terms of other metabolic outcomes, in terms of secondary outcomes, there was a 0.7% difference in the A1C, even though this is not an A1C lowering trial, even though it's a CV outcome trial, hoping for equipoise in terms of A1C reduction. Nonetheless, there was still a 0.7% reduction, and also significantly a 4-kilogram difference over time between semaglutide versus placebo. So these are the important outcomes, but again, a 21% relative risk reduction, non-statistically significant in terms of the primary outcome.
So that means when you look at the graph, the dot is over by that amount, but the tail crosses the 1. So we would say it's not significant. For sure, it means that it is not worse than usual care. And by the way, when we say placebo, it doesn't mean no care, okay? Because a lot of people get confused. Wow, we just let people kind of rot with their diabetes. So when we say placebo, it means everybody's getting usual care, And then what happens is that we add on the new medication, and then we add on a placebo pill on the other side, just so that they feel like they're doing something and they're not special and they haven't been singled out. So unfortunately, when we say placebo, it feels like we're not doing anything for them. So just remember that everybody's getting usual diabetes care, but they're not allowed to have, obviously the drug that we're studying. So therefore, the primary endpoint was met, that it was safe. And then the cardiovascular death, the total death, there was a difference. But because your main endpoint isn't significant, then this death endpoint is just interesting, but then we can't make too much of it. And the numbers were quite small. So we're talking about 40-something, I think, in terms of death. So I don't want you to walk away thinking that this saves everybody, but it certainly is in the right direction that we're seeing. Now, David, you've worked with this snack and all those kind of things, and you've worked with some of these trials. Tell us, how do you take this thing? Do you just drink water with it and swallow it?
Yeah, this is. I mean, there are going to be one or two problems with oral semaglutide. Firstly, it's not available yet. It's not been launched anywhere in the world. It's currently under review by the FDA and the European Medicines Agency. So we're talking about the future of diabetes, and it does solve this injection problem, but it does come with its own problems. It has to be taken on an empty stomach. It has to be taken with the right quantity of water. If you take it with too much or not enough, it can cause problems. Now, none of these are insurmountable. If you think about it, when bisphosphonates came out, we had exactly the same problems. In many cases, we had greater problems because of the GI side effects that went with that were far greater than we see with semaglutide. There are going to be one or other two considerations. We know that semaglutide, for example, changes absorption of thyroxine. So, and because those two medications are given commonly together, we may need to either increase our dose of thyroxine that we're giving in the morning, or maybe move thyroxine dosing to later in the day. And that should be relatively easy for us to fix. I think the biggest problem we're going to look at is going to be cost. We don't know how much this is going to be yet. It's going to come at a premium. It probably at least is going to come at a premium. And we have to remember, we're going to be giving about 50 times more semaglutide a week in order to get the same oral effect. And there has to be some cost implication that goes with that. But this is coming at about the right time, though, because at the moment in the UK, we at least are just changing the way we do our cost modelling. With the advent of these cardiovascular outcome trials, we're now starting to use cost minimization models for health economics. I'm not going to bore you senseless with all of those elements of the health economists, except to say that when we start calculating whether a drug is cost effective, instead of just using the esoteric quality-adjusted life years game, we're going to also start including the fact that people on these drugs don't put as much weight on, they don't attend hospital as frequently, they are less likely to have heart attacks or strokes, and all of those have got cost implications as well as the negative, the quality adjusted life years. So hopefully these things are all going to be taken into account when we start considering how to use these drugs in primary care.
Yeah, so Thomas, in primary care, do you think that this, I mean, it's an oral agent, and I think we were excited about it.
We're kind of horizon scanning at the moment, knowing how, it's going to take time before it's not even licensed yet, we don't know what the price is. And looking at innovations, I mean, if you talk about from bench to bedside, we're looking at sort of 10 years or more. So, and certainly when these drugs come into clinical practice, like most new innovations, which are fairly expensive, will specialised use only. So I expect over time it'll specialised use then with a shared care agreement for primary care to be involved. But clearly we need to have, in the UK at least, NICE and SIGN to have a look at these and look at cost effectiveness analysis. And I understand that these drugs may be coming in online later this year. So quite exciting, but I would say bring it back down to earth. We want maybe some further data, real world data, maybe looking at a few years down the line, especially for primary care prescriptions for this.
Yeah, it's going to be interesting because these are being fast-tracked through the agencies, because the agencies have all accepted we already have semaglutide on the shelf. We've already got clear evidence that this is reducing events and improving the quality of life. And what this is just a different way of administering it. So we're not going to see the normal bench to bedside of 10 to 15 years, but we still are going to get the experience.
Issues around injections and compliance, as we all know, even with oral tablets, how difficult compliance can be.
Yes.
So what we're hearing is that the science is there already around the molecule, and what this whole process is trying to make it easier for patients, right? Like, I mean, really, if you're a scientist, you'll say, I showed you the molecule, I showed you the benefits. But really, this is an attempt to let other people enjoy the benefits of some of these, results in terms of that. David?
Yeah, but perhaps we should also emphasize that the other benefits are the weight loss as well as the A1C reduction, which is very significant. Rarely do we see an oral class of medication that is so effective in terms of lowering the A1C by more than 1% and body weight of 4 kilograms over a short period of time. So again, these are important benefits from our patient perspective. We as diabetologists are more focused on glucose control complications, but from the patient perspective, body weight is a very important consideration, and importantly, lack of hypoglycemia. So these are very, very important benefits that could be ascribed to just the oral GLP-1 receptor agonist. So I think that's the reason why Pioneer 6 has received a lot of attention and publicity for that matter. I think it's really an exciting time.
It was a bit of a buzz at the meeting, that's for sure.
Absolutely.
And the other thing is that I think we're all very comfortable using DPP-4 inhibitors. So if you think about it, the DPP-4 enzyme breaks down the GLP-1, so that's why we blocked it, so that your natural GLP-1 would last a bit longer. So now we have an option of giving you the GLP-1 analog in a pill form. So I think that's why it may give us an extension on how do we mess with the incretin system, fixing it, without using a DPP-4, because we're running out of steam in some of the DPP-4s. We give the DPP-4, the A1Cs come down a bit, but we still need a bit more help. So therefore, that's why these oral GLP-1s may be helpful as we look beyond what to do with the DP4 and incretin systems. So I think that keep that tuned in. There will be some time, so therefore we don't have to use these agents right away. But I like the bisphosphonate sort of comparison. So when the bisphosphonate came out, remember we told people you got to sit up and drink this water and stuff like that. So similarly, we've got around that. So I think we will be able to get around those things.